Hello there, welcome to the IAPT Improving Access to Psychological Therapies presentation that myself, Rowena, Clara and Sebastian have provided for the University of Northampton Mental Health Day today. So we'll spend a little bit of time today discussing IAPT and essentially who we are, how we came to come to work in practice. We'll talk a little bit about the assessment process, the treatment process for individuals who refer into our service. And we've also got a case study where we'll kind of apply everything to give you a bit of an example of what it would look like. So, who are IAPT? So in 2006, a comprehensive report called the Layard Report encouraged the government to make psychological therapy more available to everybody in Britain. They argued that such a service would pay for itself by the reduced expenditure on incapacity benefits from people being able to go from being off sick to going back to work. So this then led to IAPT and was nationally implemented in 2008. So IAPT is designed to deliver evidence-based treatments for common mental health problems, including all types of anxiety disorders such as OCD, generalised anxiety disorder, PTSD and depression. One of IAPT's key principles is to deliver therapy at an appropriate dose. So that means that to gain optimal treatment outcomes, the duration and the intensity of treatment should vary according to the mental health problem that is being presented. And this is in accordance to NICE guidelines and the stepped care model. We'll go on to speak a little bit more about the treatment and the therapy process in a little bit more detail as the presentation goes on. But first, we'd like to show you a short clip from a YouTube video of our South team manager speaking a little bit more about IAPT and how it came about within Northamptonshire specifically.
Please. So what is IAPT? IAPT is not a household name. So improving access to psychological therapies is what it stands for. Could I have the next screen, please? So just a little bit of a background on IAPT really. Set up in 2008 following a report published to show that there was a huge gap within mental health therapy within the whole country. So in 2008 in Northamptonshire there were 14 wellbeing workers, as we were called then, employed to join up with the Changing Minds mental health service, which was in operation then. And we became the Changing Minds IAPT service at that point. So we were a relatively small team, but since then we joined up and we worked with our GP colleagues and we ran clinics for the GP surgeries. And from there, the team has grown substantially and there's huge growth. We've got over 120 staff members and we're all trained to offer therapy in an individual basis. We all follow cognitive behavioural therapy and it's CBT. So because it's such a large team, we've split the team into 3 sections and 3 areas. So the central area will cover our assessments, and the north team will cover Rushden, Wellingborough, Kettering and Corby and all the surrounding areas. And the south team, Northampton, Daventry, Towcester, Brackley and all the surrounding areas there. So it's a large area, really large area. And within that, there's a mix of both urban and rural areas. And it can be a challenge at times to make sure we can get to everyone. If can I have the next slide, please? So I just wanted to put into context a little bit about the numbers. So nationally, so the IAPT services nationally will see around about 1 million people per year. So it's a lot of people. And in Northamptonshire last year, around about 12,000 people with a bump in the road of COVID in there, of course. And at the moment, we're targeted to complete 1,350 assessments per month. Now that national target of 1 million per year is being pushed to 1.5 million, and therefore there are, we're recruiting 4,500 clinicians nationwide, and in Northamptonshire we are doing our bit and we are recruiting as we speak, really. So can I have the next slide, please? So who is it who use the IAPT service? Well, the service is open to anybody who's aged 17 and a half and above, and we will be looking for people to support people who are struggling with a range of mental health difficulties, and it's the common mental health difficulties. And as you can see there, depression is one of the main ones that we will cover, but also some of the anxiety disorders as well. And we're looking at the mild to moderate end of things. If people are struggling with a more severe and enduring mental health difficulty, then there are other services within the trust that can help and support them.
So if we start by looking at the sort of process from referral to treatment, the first step is, as I said, getting referred into the service. So there are two main ways to access IAPT. The first being a self-referral, and this can be done either over the phone by calling our hub or over the internet by visiting our website. The other way is to be referred in by a healthcare professional. Often this is through a GP or a midwife or a social worker. Referring yourself is actually really easy, as I said. All it takes is a quick visit to a website or a call on the phone. Once the referral has been made and it's gone through to our admin team, you'll receive a call so that we can book you in for a telephone assessment with either one of our assistant psychologists or one of our psychological wellbeing practitioners. The assessments usually last anywhere between 30 to 45 minutes, and the main aim is to get a really good understanding of what's been going on for you. All this information gathered will help guide the intervention that's best for you specifically. At every step within IAPT, we do require what we call the minimum data set. So this is quite simply just a few questionnaires that help us monitor how you're doing on a sort of numerical level at every stage to make sure that we're doing our job properly. These are sort of, so there's four main ones that we use, which is the PHQ-9, looking at low mood, the GAD-7, which is looking at symptoms of anxiety, IAPT phobia scales, which look at phobias, and then the work and social adjustment scale that looks at how what you're experiencing might be impacting you on a day-to-day basis. In the assessment, as I said, we'll cover lots of different information, lots of different topics, but there's a particular focus on what we call the ABCs. So ABCs are different areas and sort of talk about different factors that might be causing or perpetuating a cycle. So the A stands for autonomic. So this is typically physical sensations or symptoms. For example, if you're feeling anxious, you might find yourself with butterflies in the stomach, or you might have palpitations or feel tight-chested. This could affect things like your energy levels or your sleep. The B stands for behaviours. The behaviour section covers things like what might you be doing less of now than you used to. For example, some people that used to love going for walks or exercising might find that they're doing a bit less of that at the moment. Sometimes people might be checking things like the doors, are they locked, more often than they would normally. And sometimes people might be feeling more irritable than they used to. And the C stands for cognitions. So these are your thoughts. What's going through your head? So for example, if you're feeling down or low in mood, you might have thoughts like, I'm not good enough, what's the point? Or if you're anxious, it might be the different worries that you've got, worrying about money or whether or not you're seeing your friends enough. These different areas can be targets for all manner of different interventions, which we'll talk about a bit later on. So the questionnaires that you fill out before the appointment that we mentioned earlier will also sort of need to be covered. We want to make sure that the scores on those questionnaires are really reflective of what you're experiencing. They can also be used to prompt some of the ABC information that might otherwise be forgotten or missed. We also need to do a comprehensive risk assessment in every assessment. because it's important, first and foremost, to make sure that both you and the people around you are safe. This section can sometimes be quite sensitive, but also sometimes perhaps not so relevant for some people. We will ask questions around sort of current thoughts about perhaps ending your life, past attempts to end your life, self-harming or intention to harm yourself. We might also need to ask questions around risk to or from other people, including questions around any abuse that the patient might have experienced. Again, these are purely aimed at making sure the person in question is safe and the people around them are safe too. It's also important to get a good understanding of a variety of other factors. We like to check in about things like physical health conditions, as these can be either hamper our activity and impact our mood in some ways. It's also important to understand any cultural considerations. The population of Northamptonshire is a diverse one, and we want to make sure that we offer the right service for everyone. Substance use can also both be a trigger and a symptom of mood difficulties, and that's covered as well. And all of these factors can sort of help guide what the next steps will be. Usually we end our assessments by creating something that we call a problem statement. So this is a short summary of the main ABCs that we spoke about, along with what areas of your life are being impacted by the problem. And it usually sounds something like, my main problem is blank. I feel this way when blank. The main physical sensation I experience is, my main behavioural changes, and all this is impacting blank. We also like to think about goals for treatment, what people might want to get from treatment. We do this using SMART goals. So SMART goals are specific, measurable, achievable, realistic, and time-bound. Some examples of goals we might use are to be sleeping for X amount of hours a night within the next however many weeks, or to be exercising more within the next few weeks, or to feel confident using one worry management strategy. These are made collaboratively with the patient and the assessor in order to make them personalised and relevant for the patient. At the end of the assessment, we often end with an explanation of what the service can offer before booking in a follow-up call. After the telephone assessment, the person doing the assessment will book in a follow-up call with you. This gives them a chance to speak with a supervisor about all of the information covered in the assessment and think about what perhaps would be the appropriate next steps. Sometimes the patient will be very appropriate for the service and will likely be offered a form of treatment, which we'll talk about in a bit. However, we do lots of assessments with lots of different people, and sometimes we're not always the most appropriate service. For example, if someone has significant life events in the past that they feel might still be affecting them now, and that they need space to explore those events and talk about them, we may refer them to a counselling service, as that's more aligned with their goals. If someone is using substances, either alcohol or recreational drugs, regularly, and that's something they wish to reduce, perhaps a service like Substance to Solution would be better to support them. If a patient is presenting with risk, like, for example, regular thoughts of ending their lives with a detailed plan in place, or regular self-harming, it could be that we aren't able to manage that risk, and the patient could be referred to a secondary care service like the PCLW. They specialise more in managing that risk than IAPT do. We always like to remind our patients that if in the future, if they still need support, please come back to us and we can see what support we can offer you in the future. As I said, we don't like to leave people out in the cold. It's important to know that whatever the issue you're experiencing, whether or not you end up being suitable for our service or not, we will make sure that we find you the right support. If you are referred outside our service and later down the line you need support, as I said, please refer back to us, as we may be able to support you then, or if not, find that right service for you. Follow-up calls usually last up to 15 minutes. Sometimes these will involve getting perhaps a bit more information from you, for example, completing another questionnaire with more specific to the difficulties you might be experiencing, and in which case it might need to wait for another follow-up call before a treatment option is sort of offered. Sometimes we'll offer support right away. And as I said, sometimes we'll be explaining why perhaps another service might be appropriate.
So, Seb has just brought you through what's involved during kind of the initial contact and assessment process with IAPT. And what I'll do now is introduce you to the various different treatment options that are available if you were to be offered support with our service. So as previously mentioned, IAPT used the cognitive behavioural therapy approach and offered to those who are experiencing mild to moderate anxiety and depression. And while the approach that we use across the board is CBT, there are different modes and interventions we offer depending on what each individual presents with. The majority of people who do get support from our service do so at a level we refer to as low intensity. And by this, we mean the treatment we provide is offered on a more short-term basis, which is generally approximately 6 to 8 sessions. The goal of low intensity treatment is to empower our patients to become their own therapist through the use of guided self-help and skills development. Therefore, our patients are more prepared to manage their well-being both here and now and in the long term. So when it comes to the different modes of treatments we offer, there are 3 main ones. The first of those is one-to-one, and as the name suggests, this involves working with a therapist on a one-to-one basis, completing 6 30-minute sessions. These are structured sessions, which involve some inter-session work, in which case you'd have the chance to put the skills into practice, what you cover in sessions, and bring it back and reflect on your progress. Given the current restrictions in place, these sessions are being completed over the phone until a time in which it is safe for us to return to face-to-face work. Alternatively, there is CCBT or Silver Cloud. This involves an online program made up of modules designed to support common mental health difficulties. This could include programs on low mood, anxiety, resilience, and managing stress. As this is online, it is available to work on as and when suits you and can be a very good choice if you do have quite a changeable timetable. If offered CCBT, you have the option of accessing the program either independently or by completing 6 to 8 periodic reviews with a member of our team. These reviews typically occur every week or every 2 weeks, depending on your preference. These reviews involve checking in on your progress and potentially unlocking additional modules that you may benefit from, such as some self-esteem work or relaxation techniques. That brings us to the last type, which would be the groups or webinars. So these involve about 7 to 8 2-hour sessions, which occur on the same day and time each week. On average, we have about 8 to 12 participants in each group or webinar, and how much you share is completely your choice. We do, however, advise engaging the best you can, as this will ensure you get the most out of your sessions. Currently, our groups are being run through Microsoft Teams to ensure the safety of all of our patients and staff. As with one-to-one, group work also involves completion of inter-session tasks and feeding back to the group how you're getting on with that and the progress you've made. Webinars differ slightly to groups, as you cannot be seen or heard, but can ask questions and gain feedback throughout the session through the use of a chat function. And if you are unable to attend your webinar, they are recorded and can be sent to you after the fact. As Seb mentioned, when it comes to CBT, we are very interested in this ABC model, which involves how we feel, what we do, and what we think. When it comes to the treatment side of CBT, we aim to target one or more of these areas to bring about some positive and constructive change. For example, if we're feeling depressed and we may have lost interest in perhaps kind of going for a walk, what we would aim to do is bring back the motivation and change that behaviour so that the cycle can be a bit more productive and helpful. Next, we'll kind of look at the interventions we offer. So what I'm going to do is give you kind of a brief overview of some of the techniques or interventions we use within our service. And the decision on what intervention is used is made collaboratively, not only between the assessor and the supervisor, but also taking into account the wants and needs of the patient. So first off, we have behavioural activation, my apologies, and the aim of which is to help regain that motivation and in essence get you back to what you want to be doing and also what you need to do. So this could cover things such as meeting deadlines for uni, but also having that motivation to chat with your friends. Next, we could take a look at cognitive restructuring. So this aims to help you identify your unhelpful thoughts, look at them in a more objective way, and consider alternatives. This does involve actively challenging your thoughts. Next up, worry management, which empowers our patients to identify the nature of their worries, which could be hypothetical or practical. And say if they're found to be hypothetical, such as those what-if worries that we all struggle with, then we take a look at the tools we can use to manage this, such as mindfulness, relaxation, and worry time. If those worries are found to be more practical, then these problems can be broken down using a technique called problem solving, which involves exploring and finding the most appropriate solution and forming a plan to put the solution into place. Another intervention we offer is sleep hygiene, which is focused on helping patients achieve the most restful sleep they can through altering behaviour in order to form a more helpful sleep routine. Now, when there's the mention of low intensity, of course, there is high intensity also. And while the majority of our patients do meet their goals following completion of low intensity, we also offer high intensity support through our service. And what this essentially means is it is a more longer term support with up to 20 sessions and has two different streams through which it can be accessed. The first of which is if a patient doesn't achieve that positive change they hope to see at step 2, they may be considered for step 3 or this high intensity treatment. Alternatively, if at time of assessment, it's become clear that there is a more complex or enduring mental illness, patients may be offered step 3 at this time. Examples of presentation which may warrant this would be maybe severe depression, obsessive compulsive disorder, debilitating phobias, or perhaps trauma.
Okay, so now we're going to use the information we've just discussed and apply it to a case study. So the patient in this case study is called patient A. They are originally from Birmingham, but they are attending University of Northampton studying history, and they are in their 2nd year. They self-refer to IAPT following an appointment with their GP, who they registered to with the university, and discussed some of the mental health difficulties that they were going through. They were then booked in for an assessment when they called up the admin team within a few days, and that was with our very own assistant psychologist, Sebastian. And with their minimum data sets, so the questionnaires that they completed for the PHQ-9, which is the questionnaire that measures symptoms of low mood, they scored a 17 out of 27. And 2 out of 3 on question 9, and this question relates to thoughts that they would be better off dead or hurting themselves in some way. And the GAD-7, which measures symptoms of anxiety, they scored 8 out of 21.
So looking at what we might be looking at in that assessment, we like to ask big open questions in order to then funnel down to slightly more specific answers. So we might ask general questions such as, what's the main problem that you're experiencing at the moment? Why is it that you want some help now? Where is it that the problem tends to occur? Is it better or worse when you're with other people? And what time of day does the problem happen? So looking at the ABCs for this particular patient, we can see that in terms of the physical or physiological aspects of the problem, they're feeling tired, exhausted. They're feeling tension in the neck and the shoulders. When they feel anxious, their heart rate is increasing. They're feeling a lack of motivation. and their appetite has increased. The behavioural aspects of the problem is inactivity. They're finding themselves less likely to do university work. They're not being as social with their friends, answering phone calls or texting them. There are a lot of worries about what the future might hold, and they're checking in with their family less and generally spending more time in bed. When they're feeling especially low, you can see that they feel that there's no one there to support them, that the COVID lockdowns are ruining everything. They're thinking back to how they had such a good first year and now it doesn't feel the same. They're feeling less confident about finishing their degree, no energy, and they feel a bit like a failure. Other important questions and information that we want to gather is, whenabouts did this person start feeling this way? Were there any times in the past where they felt similar? And what are the current triggers? As we discussed earlier, every assessment contains a thorough risk assessment. So in this risk assessment, we want to focus on the fact that they have scored on the risk question, as we describe it, that thoughts about harming themselves or being better off dead. And you see the patient describes they're having these thoughts every couple of days, that life's just not worth living. They worry about their future and they just don't know how to cope. We want to know how long they've been having these thoughts. And they said since the start of the second lockdown, they've started having them. They said they've never made an attempt to end their life, but they had self-harmed by cutting during their A levels and would use a razor blade. It's important that we know the method and how often they would do this. They said once they spoke to their mum and spoke to the school, they didn't do it again, and they currently have no thoughts now. They also mentioned there's no plan or steps in place to act on a plan. And they rated their intention at 2 out of 10. In terms of risk factors, we like to think what sort of things have happened in the past or what things are happening now that would make them perhaps more likely to act on these thoughts or impulses. Past self-harm is a risk factor, as well as feeling hopeless, like there's not much going on in the future. We would agree a risk management plan with someone who's experiencing these kind of thoughts, just to make sure that they feel confident to manage their risk and that we feel confident that they can keep themselves safe. It's agreed that they'll speak to their mum when they're feeling bad, as they know that that helps, that they've also spoken to their GP about what sort of support they might be able to get there. We always like to share crisis numbers, whether or not that's through the integrated hub or the Samaritans. We also include information from crisis cafes, and that's just to make sure that even whilst perhaps they're not displaying such levels of risk right now, there might be a time where they do need that support urgently, and they'll need a service that is 24 hours as opposed to IAPT. We always like to check in with their confidence to keep themselves safe, which is why, 90% that is a good level of safety that we feel sort of comfortable leaving them with the management plan that we've put in place. Again, as mentioned earlier, we like to ensure that the people around them are safe and that they're safe from the people around them as well, which is why we ask about risk to and from others. We also like to check in with neglect, as that can also be a big factor. Not washing as much and not tidying the uni room as often as they should are signs of neglect, but again, these are things that we feel aren't an imminent danger to the person. Again, we mentioned earlier about these other important issues, physical health conditions. The patient has asthma. Is that going to affect how often they're able to engage in the sort of exercise or physical activities that we know that usually can support people's mood? They said there's no sort of cultural considerations. They mentioned financially that they're spending their student loan on things like clothes, although they're not yet in debt. Sometimes if people are struggling with financial issues, we like to offer them perhaps information regarding services like the Citizens Advice Bureau or community law. There's no issues with their housing and they're not acting as a carer. In terms of the substance use side of things, we appreciate that people at university might drink a bit more than your average citizen, but it's important that we make sure that that's a safe amount that they're consuming. So they're saying they drink a little more at the moment due to feeling bored, perhaps a bottle of wine spaced throughout the week with a few alcohol-free days. That's fine. That's a safe level of alcohol consumption to work with us. They said they used to smoke cannabis with friends once a month, but they've not done that since starting uni. That's also quite positive, as recreational drugs can affect people's mood. We're not concerned about the caffeine consumption. 2 cups a day is pretty normal. That's not going to have any effect on their sleep. In terms of the mood medication, they're saying they're being prescribed citalopram at 20 milligrams and that they've been on that for 3 days. Quite often people will think, oh, it's not had so much of an effect yet. We do know that quite often medication like that can take a few weeks to settle in. And that's something we would quite like to remind the patient to sort of persevere with that. And then in terms of finding the goals, the patient wants to find the motivation to do their uni work. They want to keep in regular contact with their friends again. They want to worry less about the future in relation to uni and COVID, and they want to be sleeping better. Whilst it can be easy to say those sorts of things, it's not always easy to actually do them, which is where we come in.
So we have a PHQ-9, that's a depression questionnaire, and that's got a score in this case of 17, which is moderately severe low mood, and the GAD-7 is an anxiety measure, so that's a measure of 8. It's just sort of borderline, that sort of mild anxiety. And how we would approach someone within the assessment within IAPT is thinking about where the level of need is. So the step 2 aspect will be including psychological wellbeing practitioners and senior wellbeing practitioners, and the aim at this point is to try and get some of those, try to reverse some of those sorts of the basics that have gone awry in these cases. So looking at someone's structure, looking at someone's routine. And I think one of the questions has been already around sort of looking at activity levels. And so it might well be that we sort of focus a lot on what people are doing with their day-to-day stuff. You know, how are they looking at the self-care? Are they looking at sleep hygiene, things that we would see as basic drives for sort of taking control and having agency and creating structure and routine for yourself. So we would always look at some of the basics, because it's quite amazing about if you attend to some of that and look at your exercise and look at your eating and looking at some of those sort of very basic things that we do day to day. If we get those right, then actually that often hugely lifts the mood, and that activity level is the first and easier place we start with depression, because it's the easiest way to shift and increase motivation. So activity increases motivation. If you get out on walks, it increases endorphins. All of those things will lift your mood. So that's often the easiest place for us to start. So people will often go in at step 2 to try and get some of those basics. Also in terms of psychoeducation around models and things, so people can get a real good idea about how the depression has developed and what they need to do to combat it in very quick and easy ways, so we can start to try and get people some sense of having some skills.
So following on a telephone assessment, Sebastian would have brought the case to his case management supervision, which usually occurs once a week after the follow-up call has been booked in with the patient. And they would have that open space to discuss the patient, what Sebastian felt were the main concerns within the case, and how we could potentially best support the patient. So looking at patient A, their questionnaire scores indicate moderate severe level of depression and a mild level of anxiety. They're presenting with somewhat suicidal ideation, but with no plan or intent, and has that history of deliberate self-harm. Their goals are CBT appropriate, so their goals were very much focused on improving communication with other people, improving motivation, but also physically wanting to sleep better. So it was decided within supervision that they would be booked into a one-to-one treatment session to try to regulate their activity and to improve their mood. And this was done at a low intensity level, so something that we call step 2. So in treatment, we would relook at the ABC model and the goals for treatment. Once that has been refreshed and looked over and agreed that actually, that is still something that the patient wants to look at, we would look at introducing an intervention that has effectively shown to elevate low mood by introducing activity. And this is something that we call behavioural activation. So, as I said, it's an evidence-based treatment used to tackle withdrawal from day-to-day activities in low mood. It works by identifying the activities that we may lack the motivation to do or the interest to do when we're feeling low or when we have little time for ourselves. These activities are then gradually reintroduced to incorporate structure, enjoyment, and a sense of achievement back into our daily lives. So obviously with COVID going on at the moment, it may not be so that we have little time for ourselves, but maybe we have too much time. And actually that can decrease our level of motivation, especially when there are limited things in which we can do at the moment. So using a technique like behavioural activation is very personal to the patient, and a lot of the techniques and the activities that are identified within this process are done so by the patient themselves with the support of their therapist or practitioner. So the first step of behavioural activation is to actually identify the things that maybe the patient is not doing anymore. These may be things, as said before, that they used to do but no longer find pleasure in, or those that maybe there's little time to do, but can also include activities that you've always wished you could do but never had the motivation to begin. So if we look back to patient A, they describe just a general amount of inactivity. They're less likely to do their university work. They're not answering phone calls or text messages to friends. They're speaking to their parents a lot less, and then they're staying in bed more. So there's a combination of things that they're doing more of and less of as a result of their mood currently. So once we identify some of the activities that they could do more of, they can then be split into 3 separate categories. Now, this can be routine activities. So these are things that maybe you do once a day, once a week, and they can be used as part of your routine. So this could be things like eating healthy meals, washing the dishes, hoovering. And then you've got your pleasurable activities. So these are things that you enjoy doing for yourself. So this could be learning a new skill, any hobbies that you might have, including gardening, for example, or socializing. And finally, you've got necessary activities. So these are things that if you don't do, there is a consequence. So this could include paying bills, completing university work, booking a doctor's appointment. Okay. And evidence has shown that in order to have a healthy balance of mood, we should try to include these 3 main types of activities as part of our weekly routine. So, your therapist is there to help you identify some of the activities, because when we are feeling low, it might be difficult for us to recall exactly what we used to do, especially when pre-COVID times seem so long ago. So they are there to help come up with examples of activities that they may not be doing, or to suggest new ones, new things for them to try that you are able to do more during the current pandemic. So then the second step of behavioural activation is to then rank the activities in order of how difficult they would be to carry out at the moment. So you would essentially get the activity that would be the easiest to do and then put them in a hierarchy going to increasing difficulty. So behavioural activation works best if it is graded. So only to carry out the activities to begin with that you feel are achievable and you could see as those easy wins before moving on to activities that may be a little bit more difficult. Okay, so a easy activity might be to text a friend or to find the phone bill that you need to pay, or to mop the bathroom floor, for example. Going up to a difficult activity, which could be to do a full month food shop, or to, ensuring that you're COVID safe, but running 10K, for example. So it's important also to ensure that within the easy, moderate, and then the more difficult activities, you still have a balance of your routine, necessary, and pleasurable within there as well. And what is also important is to break down these activities into smaller, more manageable steps, so it makes it easier to achieve. So if you've got somebody in their home and they're finding that, so patient A wasn't cleaning their room as much, you can break that down even smaller, and maybe an easier task would be to make the bed versus a more difficult task to actually strip the sheets, wash them, and then put some more back on. You could also split that down into time, so tidying the room for 10 minutes versus making it a bit more difficult and tidying the room for 40 minutes, depending on how bad it's got. Okay, so once you've got your activities ranked in your hierarchy, you are then ready to begin the main process of behavioural activation. And this is the step where you plan each of the activities that you've identified into what we call a planner. And each activity is planned and scheduled within this planner, as research has shown that when we plan something, we're more likely to achieve it. So with us doing this, we can gradually reintroduce routine, gain that sense of achievement and pleasure back into our lives. So with patient A, we're looking at, like we said, with the hierarchy, everything becoming a bit more graded. So starting with those easy activities and becoming a bit more confident, you know, and feeling a bit more positive and confident before they move on to the more moderate to difficult activities. It needs to be balanced. So looking at a wide range of the routine, necessary and pleasurable activities, and specific. So when you're planning it in, you want to know what you want to be doing, when you want to be doing it, and where you'd like that to be. So an example of this could be to clean the worktops at 4:30 in the kitchen. Okay, so when completing the planner, keeping in mind those three conditions, it's important to start small and essentially achieve those easy wins, because even if you've done one task that you weren't able to do before, that is still progress, and that should not be ignored at any point at all. So I guess the final step of behavioural activation is to complete the activities planned in the diary and monitoring your mood whilst carrying out those activities. And I guess having it written down in the method of a planner can allow you to actually physically see the benefits of increasing activity levels, and making sure that when you reflect back and you actually realise how much you have achieved and completed, that can also be a really good way to, I guess, see the progress that you are making. And it's important to be flexible as well. So there will be days that we all have, especially at the moment, where our motivation is to the floor and we really can't feel that we are able to do a certain task. And that's absolutely fine. What we would say in that instance is to just move it to another day. Have that day to rest, because that could be a necessary activity for you as well, to make sure that you take that time away and rest, but you come back to that task. It doesn't go to the back of your mind and stay there for you to continuously worry about it. You've rescheduled it. So I guess the important thing to take away from behavioural activation is that increased activity is the main thing that improves motivation levels, and it's done in a graded way, following, you know, the hierarchy that you originally created. And it's also looking at, I guess, doing it in a way where you start small, you're not rushing into anything, and it's at a sensible level for the patient in question, and it's balanced as well with the types of activities that we mentioned before. So this is reviewed and supported with one of our psychological wellbeing practitioners for between 4 to 6 sessions, where it's hoped that the patient will reach recovery and have elevated mood, and in our case with patient A, decrease in suicidal ideation. If not, there are other modes of treatment that could be considered, such as signposting to counselling or a step up to more high intensity therapy, like Clara mentioned earlier.
Okay, and if we do consider patient A, it is possible that if they presented with lower risk or no risk at all, lower scores on the MDS as well, we could consider a couple of different treatment options. So as I discussed earlier, we do have several different modes. So first off, it could be some computerized CBT, or that CCBT approach, completing a program focused on depression. But perhaps with patient A, I noticed some issues with the sleep, so we will be able to unlock an additional module which focuses on sleep and getting kind of a bit more of a healthy routine in place. Alternatively, we're currently running groups to help with the mood, one of which is called Improve Your Mood, focus on those more maybe depressive symptoms. Alternatively, we also have our webinars running that can offer some support with stress, and also one specifically targeted at coping in these COVID times. None of us were designed to cope with this, and we're all doing our best. And you always remember that we do have many different options when it comes to treatment.
And the more the step 3, I mean, it can be introduced at step 2, some initial introduction to sort of the thought work. But often when we lifted the mood and people are feeling feel a bit more motivated, engaged, and the emotional arousal and the distress is sort of removed, sort of at least reduced, we have a lot more opportunity to engage with people and think a little bit about how their thoughts might be also impacting how they're feeling. Are they thinking about things in a certain way, like I'm useless? I mean, it's a very sort of negative label to attach to yourself, and it's very globally very negative. And actually, we'll probably find that if we think about it, you wouldn't apply that to anyone else in such global terms. You shouldn't apply that to yourself. And there'll be all sorts of ways that we can start to look at that and unpick that, maybe understand where it's come from, maybe a little bit about, OK, so we understand maybe you were told that for some reason by someone when you were young and you sort of adopted it. But actually, when we look at you as an adult and the things that you're doing, there'll be all sorts of ways that we can think about how we challenge that. So that's one example of a style of thinking in terms of labelling. Is the terminology for that one in particular that we might start to look at and start to unpick. So we look at identifying unhelpful styles of thinking, we challenge thoughts, and we also might otherwise do sort of positive logs as well. OK, next slide.
Then, as a final reminder before we end the slideshow here, there are many different ways in which you can refer into our IAPT service. So this could be, again, from the GP surgery that you are part of, as long as you are registered to a GP surgery within Northamptonshire. You can self-refer through the IAPT website, of which has been provided there. You can call our admin team to self-refer as well. And then in terms of resources, we have got a leaflet there, the link under our telephone number, just giving a little bit more information about what we cover within our IAPT service and how we can help support you. And finally, 2 members of our management team recorded a video describing IAPT, something very similar to what we've done here, and some of the clips we've used from this video today, which was released on Blue Monday earlier this year. So this is a YouTube video, which again, if you would like to have a look at, there is the link there too. So we hope you found this presentation as useful as you can. Any questions or anything else that we can help to find out more about our service or to just refer, please feel free to do so. Like I said, we're here to help and support anybody in which way we can, and if we're not the right service for you, we are able to signpost you where appropriate. So yeah, from myself, Clara and Sebastian, thank you very much for joining us today.
So just currently, I know we've had a question regarding wait times as well. So I just wanted to, the wait time at the moment for an assessment within the IAPT service in Northamptonshire is is around about 2 to 3 days. It may even be a little bit less than that. It's really very quick at the moment. So I think that's something that we can really take forward, and it's just shows how easy it is to access us at the moment. We are currently really trying to support our colleagues, and so we're trying to support our colleagues in healthcare as much as possible. So we're prioritising healthcare workers. We are also, the staff are currently going through some particular specialist training to be able to treat people who are struggling with long COVID. So we're trying to look forward and to try and help people as much as possible going forward. And also we've got a long-term conditions team that is just coming on board, and we're currently recruiting into those. So that's a bit of a whistle-stop tour of IAPT and where it began and where we are and how we can access our service.